welcome back to our last session. My name is Paul Griffin. I'm a faculty member in industrial engineering at Penn State, and I'm one of the CCSA co-funds that Stephanie mentioned this morning. And I'll serve as interim director for the consortium starting in the fall. I have the honor of introducing our conference speaker, David Saunders. David is director of the Office of Health Equity in the Pennsylvania Department of Health. In this role, he's responsible for increasing public awareness of health disparities, for advocating for the development of programs to address them, and working with various constituencies to improve outcomes for underserved and disparate populations, and for collaborating with various state agencies, academic institutions, and community partners. David is a graduate of both Lincoln University and Penn State, and he's been a very strong partner with Penn State, for which we're extremely grateful. The title of this talk is It Takes a Village. And David, thanks again for taking your valuable time to participate in our conference.
Well, thank you all for having me this afternoon. I do realize that I'm standing in between you and the rest of your afternoon. So I'm going to try to keep my comments brief, and I'm hoping that we can have somewhat of an engaging conversation towards the end of your conference. So again, I appreciate the conveners of this conference. I want to say I spoke about a year and a half ago. I know I was up at Penn State at the big campus, and it was cold. So I assume it was around December, if I'm not mistaken. So I guess I did something right to be called back again. So second slide, please. So just a few things I hope to get out of today. I hope you get out of today, I should say. I want to talk a little bit about how the social determinants of health impact substance abuse disorder, and maybe even kind of hone down a little bit on how these same social determinants of health impact those that are Black, Indigenous, and people of color more acutely. And then for some of you, this may be a new concept. I doubt if it's new for all of you, but just want to introduce the concept of the political determinants of health, because what I've come to realize, maybe a little bit late into the game, is that these political determinants of health are actually the new upstream, if you will, and these social determinants of health, in fact, are midstream. Next slide, please. So the pandemic and much of the work that I do now as the director of the Office of Health Equity is focused in on the pandemic. And I don't think that's a surprise. I had not done much in the area of preparedness, emergency preparedness. When we first got the call, if you will, that we needed to vacate our building, and this is real. I said to my colleague that we need to have an equity response, because those folks that are most vulnerable in the state are going to be impacted greatly. I mean, we are all, dealing with the same storm of COVID-19. But those of us, many of us that are on this call, participating in this conference, in fact, are in a better position to weather the storm. We're not in the same boat as those that are in rural Pennsylvania, low income, urban residents in both rural Pennsylvania as well as urban Pennsylvania. And I'll get into a few other factors. So while we're all dealing with the same storm, we're clearly not in the same boat. Next slide, please. So from a mental health and substance abuse perspective, what does the impact of the pandemic look like? I think it's, again, different. we all have a higher level of anxiety. I recently, through Penn State Health, I got my first shot, and I'm looking forward to getting my second vaccination shot in a couple of weeks. But I've had bouts, I want to say, of depression because I'm just tired of all the things that we're dealing with, and I have anxiety. I think like many people have. I don't want to get the virus, and just how much things are different. But I don't have some of the issues around, that many people have as it relates to loss of income. I have a job. I have a good job. I have a job that's at this particular time pretty well sought out and resourced. So I don't have the issue of loss of income, but those that do have increased levels of depression and anxiety. Women and children, I think, again, being in the cocoon that many of us are in. Some of you, are parents on the line. Some of you, have to deal with both working. You may be doing that right today. I mean, many of you are. You're working at home. You have your children behind you or in another room, and you're trying to, get through the workday unscathed. But yet, being resourced allows you to, in some cases, we're in a position to hire nannies. So we're in a position to, find suitable childcare for our children. Whereas if you're a single mom, if you're a low-income mom, you may not have those same resources. And thus that the additional stress that puts on you, you want to do the best that you can do, increases your levels of anxiety and contributes to poor mental health. People of color, I've recently read an article. If I get smart about it, maybe I'll drop that article in the chat if I'm not get that savvy. But people of color have reported higher levels of anxiety and depression. And is it any wonder that is the case? Because again, here we are in the same storm. We're all dealing with the same overall problem, which is rare. But the level of anxiety and depression is increased when you lump on to all that we're dealing with this pandemic, with all the different things that are going on. From the racial unrest, to police brutality, to just being a person of color, with all the myriad of things that a person of color has to deal with on an everyday basis. And those that are essential workers, and that runs the gamut across, race and ethnic groups, even though many of our essential workers happen to be people of color. But again, that runs the gamut. Those essential workers have to go in. They're not working behind, like I am today, my home desk. They have to go in and be behind a counter at a grocery store and that type of thing. And because of that, they're reporting higher levels of anxiety. Because they're worried about getting the virus and all the things that have come with this pandemic. So next slide, please. So what I wanted to do is I wanted to speak a little bit about equality versus equity. And I know many of you have seen, this particular slide that depicts equality versus equity. You may not have seen this one. This particular one takes it a step forward and looks at justice as well. So we start off with inequality in the upper left-hand corner. and we see that something is structurally different, something is structurally wrong with the tree on the left. When you look at it from an equality perspective, so we're talking about on the right, this tree is leaning to the left. If you pay close attention to the distribution of apples or the resources on the tree, you see that there is far more resources on the left-hand side of the tree because it is structurally broken. I think that's key to dealing with issues of mental health that impact people of color on a larger level. There's something structurally wrong with the system that we have currently in place. So you can see that the kid on the left can get the resources and apples dropped without even trying very hard. Some may call that privilege. Now to equality. Now we're going to give them both a 6-foot ladder. So yes, we're providing the same resource, but it doesn't provide the same amount of resources. So that really helps the kid on the left because, again, there's something structurally leaning in his favor, and the kid on the right still really can't do anything even with the same tools or the resources being given. Because again, there's something structurally in place that reduces the benefit of the tree that they both have in front of them. So when we can have a conversation about equity, which is the kid on the right clearly needs an 8-foot ladder to use the tree. And sometimes people will look at equity as saying, well, you're taking something from me if you're giving it to that person. And that is an issue. And we're going to talk a little bit about it shortly in regards to the political determinants of health. So the kid on the left, he can reach the tree and he can access some resources. Actually, the kid on the right can access some resources, but we haven't fixed the problem that there is something structurally wrong with the tree. And it is still producing more resources and still leaning to the left. So now we can have a conversation, and we should, about justice. We recognize that this is crucial, that we're going to need to fix what is structurally wrong. And then once we do that, now we see there's an equal distribution of resources throughout the tree. And now we can have a conversation about equality, because now that we have fixed the structural issues, now we see that a 6-foot ladder is sufficient for both of them to have access to the same amount of resources. Next slide, please. So many of you have seen, this before too. And, actually I'm gonna lay it out in 2 different ways. So looking at the social determinants of health, and I know you've had presentations relative to education and substance abuse, healthcare and substance abuse, and the last piece was on the faith-based community and substance abuse. All of those entities are part, of the social determinants of health. In fact, it's basically, where we live, work, and play. And, looking at this diagram from left to right in regards to economic stability, which really drives much of our healthcare, of our health, which drives our health. And really, it's the engine to everything. I mean, if we eliminated poverty, chances are many more individuals will live a longer, healthier, and happier life. So looking at economic stability, employment is huge. Of course, employment brings with it income, but there is a disparate income level between, in many cases, people of color and our non-white counterparts. The expenses that we have, many families, and not just people of color, many families have to weigh certain expenses, and they may not put health at the highest level that it should be, because they have to determine based upon their expenses, whether they're going to put nutritious food on the table or not, whether they're going to seek out health care or not. There have been studies that have indicated that medical bills tend to prevent people from going in to see the doctors. If I have a medical bill that I can't pay now, well, why am I going to go to the hospital or my healthcare provider where that bill is going to be higher? It's going to be lumped on to what I already have. And again, there's the support mechanisms that are in place. Looking at our neighborhood, I can walk out my door today. I live in Lower Paxton Township, right outside of Harrisburg, and I'll underline outside of Harrisburg because I don't live within the inner city. Those folks that live in the inner city, they are dealing with housing issues, whether those houses are safe, well ventilated, lead in the homes, whether they can find suitable housing. Those same individuals, whether they be in the inner city or in rural Pennsylvania, have transportation issues. Our friends in some of the rural parts of the state have medical facilities that are 30 to 45 minutes away. We have some counties in this state. And my last number that I knew of, there's about 22 counties in the state of Pennsylvania that don't have birthing centers. And if I don't have transportation, or if my transportation is not is ill-equipped, or if it's snowing outside and I'm living up here, on this hill, and I have to get from where I'm at to a medical facility to give birth, transportation is a huge issue. Not to mention the transportation to get to other resources outside of healthcare. The safety that's within our communities. Again, I don't have to worry about my safety when I walk out the door, but there are many communities in urban Pennsylvania, but also in rural Pennsylvania. Rural Pennsylvania dealing with something different, but sometimes safety issues reduce our ability to walk and run and ride a bike. And again, all those things contribute to our mental health. Same thing as it relates to playgrounds and walkability. So the things here about education, whether it comes from literacy and language, I won't go down the list like I just did with the other two. There are many families that are dealing with hunger. Because if I have to make a decision over a roof over my head or food in my belly, I may, unfortunately, I may have to choose that roof over my head and pull back on what we eat. And in many cases, either I don't have access to much more than fast food restaurants, or I don't have the funds to pay for those, for more nutritious food. And when I'm dealing with all these different things, the support, the connection to, it's kind of like looking through the window of a store and you see all these shiny toys, but you're not necessarily in a position to get any of those shiny toys. You're not connected to the mechanisms that provide you with access to all the things that make one healthy. You're not tied into it. You don't have the supports. You're not engaging with the community. You're in your own space, and you don't. You're not in the position to achieve some of the things that you're dealing with. And if you're a person of color, you have historical discrimination that you've been faced with and still are faced with. And that tends to be about 80% of what contributes to health. But then you have that last 20% looking at whether I have health coverage or not, the availability of reputable health providers. Again, if I'm in rural Pennsylvania, there's a dearth of medical providers in many of our more rural counties, or if I'm in urban Pennsylvania, they may be, I may live in West Philly, and downtown Philly, there's plenty of healthcare providers, but if I don't have the funds or the access, if I don't have the insurance that provides me access to those folks, well, they might as well be 100 miles away. And all those other things that fall under healthcare all connect, and I should point this out as opposed to glossing over it. We do a lot of work in our office around culturally linguistic appropriate services. There are many different languages, many different beliefs, many different cultures, more so than Black and white here in the state of Pennsylvania, which is different than what it has been over the last 5 to 10 years, and it's only going to continue to be different. How are our healthcare providers positioned, or are our healthcare providers positioned to deal with all the languages and the cultures that are found here in the state? And of course, not to mention quality of care, and all these things impact health outcomes. I know many of you have studied this type of thing, maybe as it relates to substance abuse and mental health, and all these things tie in to each other. Next slide, please. This is just another way to look at it. This figure breaks down how different health factors contribute to health outcomes, such as length of quality or quality of life. Typically, when people think about what makes a population healthy or unhealthy, we first think of health behaviors. But if I don't have access, as one example, if I don't have access to nutritious food, I can't make the choice to eat healthy. I don't have access to healthy food. If I am, as an example, in a community where billboards are prevalent that advertise smoking and drinking, well, maybe there's a good chance that that's what I'll do, because that's what's pushed into my face. And we also look at the clinical care setting as being integral. And again, it is, but as we saw from the other slide, as well as this one, research documents that these two factors only account for 50% of what contributes to overall health. The other 50% are, those social determinants of health that I mentioned a little bit earlier and that are depicted here. This represents the social and economic factors and the physical environment that's displayed in this particular figure. Next slide, please. So how does this all relate to substance abuse, mental health? You have to go back a little bit. I was around during this time. In 1971, Nixon declared a war on drugs. He didn't look at, and you'll hear this as a reoccurring theme, definitely from this point on, he did not look at the root factors of why people buy and sell and do drugs. He just looked at the political ramifications of it at that time. And he even rejected in 1972 a study that indicated that it should be decriminalized. So that was kind of the start of it. It pervaded in the 80s and 90s with the war on drugs, I should say. And that war on drugs really increased the amount of Black and brown people who are in jail. And if you kind of peel back that layer a little bit, you look at the number of African Americans and Latino men and women who were in jail. If that contributes to some of those other factors that I pointed out a little bit earlier, in regards to, in some cases, single mothers. In many cases, if you don't have two people earning wages, whether mom and dad are together or not, your economic status or your ability to live a healthy life is diminished. So one thing connects to the other, and I'm really glad you folks looked at all the different sectors that kind of impact all these things. So at least you looked at some, because one definitely connects to the other. Let's just say that Just Say No and the DARE campaigns really did not do much to reduce the abuse of drugs. And now I do want to juxtapose this, and I'm not going to spend a lot of time on this. There is a difference between how those that were addicted and sold crack cocaine, those that sell even marijuana to this day, use marijuana to this day, and how those individuals were referred to as addicts and druggies. And back in the day, the hippies were categorized in a certain way because they were not really amenable to the war at that time, and how individuals now are looked at who are opioid users, and it's different. It's treated as it should be, in that substance abuse disorder is a disease that should be treated like a disease, as opposed to an individuals that are committing crimes. And I bring this to your attention. I'm sure many of you kind of can relate to this, just so that we are cognizant. You can't face something that is not illuminated. So I just wanted to kind of lift this up a little bit. There is a difference between how folks were treated then and are currently being treated. Next slide, please. So I did want to introduce this this concept of political determinants of health, and then what I did not say in my learning objectives, I do have a few opportunities for improvement, some things that we could do as a collective to reduce substance abuse. But let's get into what I'm calling, next slide please, upstream work. Again, previously, for me and many others, we looked at the social determinants of health as upstream work, where you wanted to kind of look at the root, look at those housing issues, the education issues, things that I talked about a little bit earlier. But in many cases, those factors are determined by politics. So Daniel Dawes wrote the seminal book on the political determinants of health. And it's a fantastic read, and there's been a fair amount of work that's been done since then. It talks about the distribution of resources. I mean, you can look at the pandemic as we speak and the resources that have been provided relatively quickly. And I'm going to take politics out of it to a certain extent, but we need to consider kind of how these things go. So trying to be somewhat apolitical, since we've had a new administration, things have drastically turned around in regards to the vaccine. Funds pretty much out of the sky to many of our accounts. Resources around, I can tell you from a public health perspective, there are many resources that are coming into the Department of Health around COVID-19 or as a result of COVID-19, much discussion and resources are being provided around equity. And it's based upon political will. It wasn't that the resources weren't available. It was the will that seemingly wasn't available, if you will, to move some of these things forward. Who wields the power can really determine, funding and policies and practices, even the words that come out of our leaders' mouths. I mean, our president has mentioned the word systemic racism, equity. Our governor has mentioned the word systemic racism and equity. That makes a huge difference. Politics drives, and it's not something, I think the concept is new, calling it the political determinants of health, but we've always known this. It's really just kind of connecting the dots, one thing to the other. Next slide. So I promised you that I had a few suggestions, and I'd like to go through them now. Then it looks like we'll have about 10 minutes, which is good, to have a discussion. I'm looking forward to that. So this is clearly not an exhaustive list, and probably some of these things you've already thought about, but just to bring a few things to your attention, lift them up, elevate them, if you will. So I know many of you have done fantastic research in a variety of different areas. I love the work at Penn State. I'm very proud of being a Penn State alumni. I got my master's degree in education way back in 1994 off the campus of Penn State Harrisburg. Wonderful teachers, wonderful professors, wonderful research you all are doing. I would just encourage you to look at things through an equity lens, as we kind of discussed a little bit earlier in the presentation. The tree is leaning to the left. It clearly is, and always has been. I think the thing I'm excited about is there is work being done as we speak. There's so many different people that are interested in writing the tree and in looking at the structural issues that contribute to the lack of health for some people and the relative health for others. So I'm really excited that there is that work, and I have seen some research that's looking through an equity lens, looking at it from a standpoint of there are needs that some people have versus others, whether they be disabled, whether they be over the age of 65, whether they be from the LGBTQ community. The research needs to look at the needs of individuals that may be different from from across the board standpoint, from just your typical person. I don't know if that's the best way to say it, but just looking through that equity lens from a research perspective, I think is very important. So you all have heard from various sectors, and that's crucially important because, it takes a village to really impact issues that are pretty complex, pretty large, multifaceted. Within the Pennsylvania Department of Health, and specifically my Office of Health Equity, we have something called the Pennsylvania Interagency Health Equity Team. And actually we have I'll call out Mike Donovan. I don't know if he's on the line. We have Mike Donovan from Penn State, and we've had others from Penn State that have participated on the Pennsylvania Interagency Health Equity Team. Susan McHale, I hope Susan's out there. We have agencies like aging, transportation, and ag, did I say education? Transportation. We have 15 state agencies that meet on a regular basis looking at equity issues, because it's so key that you look across sectors to impact these issues. I'm on our health equity response team. We have a health equity response team that's been in place now since April 2020. We have individuals like yourself, so from academia, we have healthcare, we have state agencies, because again, these issues are so multifaceted. It's incumbent upon us to work with various sectors. Community-based organizations, nonprofit organizations are part of both PHED as well as our health equity response team as well, because it's extremely important to do so. And one thing I know that we are missing, and I think this is where cultivating diverse voices will come, and I'll go back up to translating data in a second, is if there's a hole in our game, if you will, is we don't talk with and engage, I should say, people that have lived experience. So those individuals, we don't do enough of it. We do a little bit of it, but not enough for those that are dealing with the issues that we are trying to impact, not for us, without us. And lastly, now I'll go back up to translating data and research for the layman. What I've encouraged various individuals within our department is make it easy, make the information easy for people to access and understandable for Pennsylvania residents that are not part of the public health department, not part of Penn State, to use the information. So all this great research that you all do, and I know you have several arms of Penn State that do this type of thing, where you translate that data and you make it visually appealing and useful. The more of that, the better. Next slide, please. This really brings me to my last slide. This is pretty much my last slide. Just to reiterate the importance of getting at the root of the problem, that it is crucial that we address, what's below the surface. We have to dig deep, explore, what are the real issues. What is not apparent is what needs a light shown on it. What is clear needs to be illuminated and focused upon. And I want to thank you all for paying attention to me, hopefully, and I look forward to your questions. Last slide. So I don't know if there are questions that folks have.
Yeah, so we have a couple of questions. So one is, you discussed how healthcare is responsible for 20% of health outcomes, with 80% occurring outside of this setting. Unfortunately, many of our systems are still very much siloed. Do you have any specific recommendations for how healthcare systems and other systems can start to work cross systems to address health equity?
Yeah, actually, I've seen it. I mean, many of the healthcare departments, healthcare providers, I should say, have diversity, inclusion, and equity folks on staff. I've seen many healthcare organizations that are addressing some of these social determinants of health. I lived and worked in California. This is just a very small example. And my healthcare provider was Kaiser. And I would go to see my doctor from time to time. and there would be a farmer's market in front of the entrance to get into the facility. You know, I have seen healthcare providers, you know, do some work around housing. So they try to get outside of their buildings, if you will, outside of their four walls. I've seen, you know, advisory boards that bring in community partners. Right now with COVID-19, healthcare providers are working with, I know you had faith-based session earlier, so many healthcare providers are working with the faith-based community. I would strongly encourage working across sectors, working outside of your buildings, because really it's going to, it reduces the impact, if you will, of you not working across sectors. You know, because you're going to get people coming to you for the for things that are not emergency situations, but that's when they wait to come to you. When it's an emergency situation, I should say, and as opposed to preventive care. So it's just a few examples.
Thanks. And another question, I know you have a hard stop at 3:30, but maybe you'll have time to answer this. So the title of your talk was It Takes a Village. And of course, the point today was to talk about different systems, as you mentioned, healthcare, education, criminal justice, faith-based. And in your role, you have to work with many different types of constituencies. And I'm wondering if you could say a bit about how you're able to do that. Do you have any sort of methods that you think work well for bringing people together to address these hard problems?
That's a good question. I think your basic communication skills, listening, you know, hearing, you know, articulating clear messages, you know, feedback, you know, providing time and space, thanking people. You know, I'm still surprised that even after more than a year, we have our health equity response team calls, and we'll have 85 to 100 people on the call. We try to keep everyone engaged as much as possible. We try to keep the information fresh. I know Jen and the folks from Reach, and I mean, you guys do this kind of thing all the time as well. But really, it's you know, making sure that it's genuine engagement, and people also want to see, I think, results, and kind of how they played into, you know, those results. So I think, again, that constant feedback, okay, well, this is what you gave us in the way of information, this is how you contributed, and with what you've contributed to us, this is how we have been successful. So yeah, I would say, I guess if I had to boil it down, your basic communication skills, and making sure people feel that they have contributed to the overall success of the effort.
And I got one last question that I feel like I need to ask, and that is, what more can Penn State do?
Oh, well, I would say that you all are doing a fair amount already. We have great engagement with the folks from Reach, great engagement from Mike Donovan and his team. I haven't heard from Susan McHale a little bit, but I know she's out there. I would say, I mentioned the diverse voices. I think hiring more people of color, and not just hiring them, but engaging them, letting their voices be heard and, you know, felt to be more comfortable. Maybe getting into some of the more uncomfortable, or having more of these uncomfortable discussions around racism, specifically. We have an anti-racism institute that we are currently engaged in. And there has been some uncomfortable conversations that have occurred. But kind of once you get over those uncomfortable conversations, you could move forward to improvement and, you know, policy change. So I would encourage Penn State to look at that. And just, I would say, keep on doing what you guys are doing. Somehow get as invigorated as you possibly can. Look at it as a, in the long term. It's not a sprint. It's a marathon. So we just, as a Pennsylvania Department of Health, I guess me personally, just hope that Penn State will continue to be a partner and will, even increase their effort going forward. You have many resources, at the big campus, but throughout the state. And I think there's great opportunity. I think in some of the more rural communities, the racial and ethnic minority communities have been increasing. Reaching out to students from those communities would be fantastic. Those are just a few things. I could probably go on, but those are just a few.
Great. Well, on behalf of the consortium, I really want to thank you for taking time out again for your really thought-provoking talk. And again, thank you for sort of all of your help and engagement in the past. And we really look forward in continuing that process with you going forward.
Same here. Thank you very much.
Yeah, great. So we're going to finish. I'll hand it back over to Stephanie. We'll finish.
That's it. I just want to say thank you all for coming, and thank you, Paul, for sharing that great session. And so grateful for David's partnership. Have a good day.